shoulder. So the shoulder is one of the regions and one of the joints that, to constitute a full exam by the AAUM standards, we need to evaluate the whole joint, not just in regional terms as we've done with the hip and the knee and the elbow and the hand and the wrist. So starting in sequence, we're going to start with the biceps long head, and we're going to view that in two planes. And second from there, we're going to move to the subscapularis, view that in two planes, as well as dynamically and look at its relationship underneath the coracoid, make sure there's no effusion and that sort of thing, and we'll watch the shoulder internally and externally rotate and look for the quality of tendon gliding in that view. And then we're going to move laterally and posteriorly and look at the infraspinatus, its insertion and footprint, as well as slide back posteriorly, identify the muscle tendon junction. And in that view, we're going to look at the posterior superior rim of the glenoid labrum and look at its quality of gliding and its relationship with the humeral head dynamically. That's the one view in the shoulder where we get a decent picture of the labrum. And next, we'll reposition the patient and look at the supraspinatus and the anatomic footprint of that tendon. And that's where we're going to see most of the pathologies. And when you get out in these clinical applications, you start applying ultrasound in your practice, you'll see the majority of your shoulder issues. If it's a rotator cuff problem, you will see most of the issues at that insertion. And lastly, the acromioclavicular joint, we will look there. And additionally, we will also, and this is not part of the standard exam, but sometimes when it's clinically indicated, we will take a look at the coracoacromial ligament and look at the quote-unquote roof of the rotator cuff. We can see a lot of problems there, maybe hypertrophic changes of the ligaments, some bursal adhesions underneath it. And nice part about the dynamic aspect is we can put the patient in certain testing positions in viewing those things. So we're going to start with the biceps. We like to start in short axis. Okay, so let's identify where the bicipital groove is. Sometimes with these patients, so if you look, patient's really at neutral in this position, and see how the groove sits off laterally. So let's just internally rotate his arm and find it so we get it more central in the screen and get it more parallel with the beam of the transducer. So in this view, I'm right at the proximal aspect of the groove. Okay, here's the bicipital groove starting to form. Medially, this is the lesser tuberosity. Now laterally, this is the greater tuberosity. And this structure right in the middle is our bicep tendon. I'm going to move distally and heel in. Okay, so right here, when I say heel in, I'm going to move the probe just like this. And see how you get that picture to come in? Notice how when I was up here, see how it's dark? That's called anisotropy, where my transducer beam isn't exactly 90 degrees to the structure I want to identify. So I need to accommodate and heel it in, okay? I'm going to freeze it. So this is a better picture right at the mid aspect of the bicipital groove. We have a nice fibrillar pattern hyperechoic structure right smack in the middle. Over the top, this is the transverse ligament, okay? Left is medial, right is lateral, lesser tuberosity, greater tuberosity, bicipital groove. Okay, so unfreeze. Now I'm coming back. I'm going to move distally. Watch these structures change a little bit. The groove's going to flatten off. Keep your eye on the tendon. You want to scan the level of where the pec tendon starts to come in. Okay, so the biceps is starting to turn into muscle. The pec tendon will start to come in from left to right. And freeze. This is the pec tendon coming in. This is the bicep long head turning into muscle. This is the bicep short head on the left. Okay, so moving on from there, whatever you look in one plane, you got to look in two. So I'm going to look in long axis now. Okay, so starting proximally, I want to identify the tendon in long axis. So again, this becomes as much of an art as it is science. Once you have the clinical knowledge as far as where anatomically things are, this becomes a motor skill with you and the transducer. The ultrasound picture is only as good as the individual who's using it. This hyperechoic cortical line here is the humerus. We're looking longitudinally now in the bicipital groove. Left is proximal, right is distal. Over the top, superficial. We have the skin layer, the subcutaneous layer, myofascial layer, anterior deltoid from here to here. This is the bicep tendon and long axis. We have a nice fibrillar pattern running through. This is a nice healthy tendon, exactly what a healthy tendon should look like. Let's find it again. Okay, so once you have this picture, we like to follow it down. Now look closely. We're starting to run into muscle belly on the right. Okay, so here's our myotendon junction, essentially right here. Nice hyperechoic structure. This is vasculature here, okay, where you see this hypoechoic line in the tendon. Tendon's running left is proximal, right is distal, running in, and you start to see the muscle formation here. Okay, that's essentially, that's about the level you want to follow it down to in long axis. Now, moving to the next structure, remember, the nice thing about the shoulder in the shoulder exam is essentially the same, you're going to utilize the same palpation techniques you're going to utilize without, you're very stiff. Okay, so we're going to rotate this patient externally in the shoulder to view the lesser tuberosity and the attachment of the subscapularis. Okay, so this bird's beak formation here, left is proximal, right is distal. This is our subscapularis moving in, okay, at the insertion point. Let's move them back again, and then we'll start to look around a little bit. So again, your bony landmarks are key. If you're not getting good pictures of your bony landmarks, the structures that are adjacent to it aren't going to be as crisp, and you're not going to get the evaluation you want. Okay, so let me just say that. So with anything you're looking at an ultrasound, you need to have nice, crisp, bony landmarks to clearly identify and be confident with your diagnosis and your evaluation of the structures you're intending to look at. Okay, so again, this is our subscapularis and long axis. Now let's look at this subscap. We're going to move immediately and identify the coracoid process. Here's the coracoid process. Here's subscap muscle, and tendon is to the right of it. So as we internally rotate, watch this tendon move under the coracohumeral interval, okay, and we're looking for quality of gliding, bunching, we're looking for any effusion in the subcoracoid recess. So the subcoracoid recess is just a fancy way of saying there's a recess sitting underneath the coracoid. It's a potential space for fluid to accumulate. If there's joint irritation, big rotator cuff tears, you will see some fluid kind of dispersing through here, and it will separate itself from the tendon. Okay, and in this case, we don't see that. This hyperechoic structure right here on the top, this is the coracohumeral ligament. Okay, we're catching a little band of it. Okay, we're not seeing the true attachment site of it, but just know that it's there, coracohumeral ligament. Okay, and that's the coracohumeral interval. Essentially, that's the retinaculum for the subscap to travel underneath. Okay, now looking in short axis window of the subscapularis at the lesser tuberosity. Remember that the subscap is a multipennate muscle. These bright white hyperechoic lines in the subscap are not calcifications. These are the tendon bundles. So you're going to see, as I kind of move around, you're going to see, nope, stay here. You're going to see three distinct tendon bundles. 1, 2, 3. Okay, this is the multipennate structure of the myofibrils of the subscap, and this is what they look like, and these are completely healthy, completely normal structures on this patient. Okay, so moving on from there, I'm going to position the patient. There's two different ways to do it. Now, you see some textbooks like to have the patient like this to look at the infraspinatus. I like to prefer this. It really depends on when I get the probe on there, what do I see? Sometimes I have to change it on the fly, and there's no one universal way of doing it. Let's start right here and see what we see. Okay, so let's look at the infra in short axis. How do I know it's the infra? Well, we know the infraspinatus origin is in the infraspinous fossa, okay? So it's going to wrap around and come to an insertion on the greater tuberosity. And also understand that the greater tuberosity has different facets as well. The inferior facet is the true insertion of the infraspinatus. It actually overlaps the supraspinatus, which inserts on the superior facet. Okay, so how do we best identify it? We're going to start in short axis, okay? Because I know for the novice person, when I was starting, and for those of you who are learning, you want to be able to find the acromion. Okay, so I'm in the coronal plane here. This is the acromion. When I drop straight down, I'm going to freeze right here. I know this is the infraspinatus because like I mentioned before, you all know, well, I hope you know the anatomy, okay, as the infra comes around, wraps around. This can't be anything else, okay, because remember the supraspinatus we can't see unless we're going to expose it from underneath the acromion into extension. This patient is clearly not in extension. He's in adduction and internal rotation. Okay, so we're putting the infra on a bit of a stretch. So this is our short axis picture of the infraspinatus. This bright white line here is the peribursal fat line of the subacromial bursa. Okay, lateral deltoid muscle over the top. All right, now from here I'm going to turn it long axis, and we're looking at a bird's beak appearance of the infraspinatus. Now we get a better picture. Again, bony landmarks are key. Okay, so here is essentially the insertion of the infraspinatus. Teres minor, yes, you can see some of it. We're not as concerned with the teres minor because clinically, how often do you see an isolated teres minor tear? Very, very rarely. I don't think it ever happens. But essentially if I move down, so infraspinatus is up top and it's more robust and thick. If I slide down in this view just slightly, see the tendon really thin out? This is more of the teres minor, okay? So you can separate the two, and we can separate the two when we look posteriorly in the fossa on the muscle bellies. Okay, but for now, we're going to follow the infraspinatus. I'm going to walk it back, so keep the humeral head in my view, and watch the infraspinatus turn into muscle. Now in this picture here, we're going to freeze it. Infraspinatus muscle, humeral head, posterior rim of the glenoid, and then this triangular structure here is the labrum. Okay, so we're going to look dynamically how they move. Okay, so internally and externally rotating the arm. Watch as the humeral head spin on the labrum. We see that myotendon junction of the infraspinatus moving. The hyperechoic, if you're watching the gliding above, the hyperechoic lines delineate tendon versus hypoechoic as muscle. So you're watching a nice clear picture of the myotendon junction move in this view. And the labrum is relatively stable. We're not seeing what we call a geyser sign when this moves into external rotation. The infraspinatus will keep going there. The labrum will just jump out of his joint space. Okay, we're not seeing that here. We're seeing maybe a little bit of fraying, but nothing that would constitute a pathologic sign. Okay, so that's good there. We're going to move on to the supraspinatus. Now, the supraspinatus, like I mentioned earlier, the best way to see it is we have to put him into extension, okay? So we're going to put this patient in what's called the cras position, or in this view, actually, nope, flip around the other way, the semi-cras position. So you put your hand on your hip, and I'm having you scoot forward in your chair so you're not touching the back. Good. And then put this elbow into a little bit of extension. So we're really putting the shoulder in extension, exposing the tendon from underneath the acromion. All right. Now, in this view, we're going to start in long axis. So we're going to look. So how do I know it's supraspinatus? Well, I know where the biceps is, okay, and we know that the supraspinatus is lateral and posterior to the bicep. We're seeing bicep fibers here. I'm going to move slightly lateral to it. And the first structure you move into, this bird's beak, is the supraspinatus. Okay, so I'm going to go over a couple important landmarks, okay? The footprint of the tendon is about 12 to 16 millimeters. Okay, so if I'm correct, if I'm in that range, the articular surface of the humerus starts to drop off right here, and it forms the ball and moves into the humeral shaft off to the left. Okay. The footprint is from here to here. So I'm about right. It's 11 or 1.14 centimeters, 11.5 millimeters. Okay, so we ballpark that just about right. And then from here down is your articular margin. So just so you understand bony landmarks, you understand the anatomy. We're not just anatomy generalists. You have to be able to master these positions. Okay, so keeping our patient in this position here. Again, let's find that view. See how this hooks in? This is this hump right here. This helps us separate kind of the footprint of the insertion versus the articular margin of the humerus. And our tendon is basically from here to here. Okay, subacromial peribursal fat layer is basically from here to here, and then over the top is our deltoid muscle subcutaneous layer on the very top. Okay, now some nice things you can do with the ultrasound that separates it from other imaging modalities is the dynamic aspect. I got you, let me just take your elbow. Okay, so what we're looking, I'm just wagging this patient's elbow through kind of an assisted range of motion into extension. Okay, what am I doing in extension? Well, I'm stressing the footprint of the rotator cuff. Okay, if there's oftentimes with big retracted tears, what you see when you put the patient into extension, you see some tendon retraction. You'll see the tendon move one way, the bone move the other. As you see what we call this paradox of movement between the two. The tendon-bone relationship, okay? But in a healthy shoulder, you'll see them both move at the same rate, which is what we see here, okay? So whatever you look in one view, you look in another. So I'm going to turn it into short axis in this view, and I'm going to come up on what we call the rotator cuff interval. Okay, so in short axis, humerus, greater tuberosity. We have the biceps long head tendon right here. This hypoechoic appearance just lateral to the biceps is there's some capsule in some of the glenohumeral ligament in this picture that gives it that appearance. This is not pathology. And this hypoechoic line kind of adjacent to the humerus signifies that I'm really probably at the articular margin in this view, meaning the reason why is because the articular surface of the hyaline cartilage gives a hypoechoic appearance because it's high in water content. And above it, this hyperechoic layer is the tendon, and then the bursa is this bright fascial line superficial to the tendon. Okay? So back to that. Let's get back to that view right here. Okay, so we have bicep, humerus, articular cartilage, tendon, bursa, and the deltoid. This is darker muscle. Remember, muscle is high in water content. It's going to be darker than the tendon, so you get a nice contrast between the two. All right. Now, from here, you like to scan. Okay, so scan just anterior, scan posterior. So see how small I'm moving? We're talking millimeters. Now, I'm not just going back and forth. You're not going to see anything like that. You have to move in small little planes, constantly adjusting. So like I said, it's a motor skill. Once you understand the anatomy and you want to get good at ultrasound, you have to practice. It takes hours. And looking at a lot of healthy patients, okay, and understanding what normal is, because if you don't know what normal is, you don't know what abnormal is. So you have to be able to differentiate between the two. Okay, so I'm anteriorly in this view. That's essentially my rotator cuff evaluation, okay? Not a lot of you could do some dynamic studies in this picture where we're watching it move in short axis, see how the tendon is moving with the bone, moving with the biceps at that bicep pulley location. This is a nice healthy tissue, so we're not seeing anything atypical here. All right, have the patient relax. Let your arm hang down. We'll look at the AC joint up top. So he's got a nice healthy AC joint. So good, good representation here. On the left is the clavicle, on the right is the acromion. The space in between is the acromioclavicular joint. Joint capsule is this hyperechoic line on the top. So we have this is some superior ligament that we're seeing here, okay? Now to the other view I mentioned, the coracoacromial view, okay? So these are not required by the AIUM, but these are things that it's nice to have in your back pocket when you're really looking for these patients who have compressive impingement syndromes. Maybe they don't have any overt signs of rotator cuff tears or pathology, but you just know there's something going on. Well, you can help kind of get an idea of what's going on in their shoulder. So what I'm doing here is, on the left is the coracoid, okay, and to the right would be the acromion out here. See this bright white structure? I'm going to freeze, okay? Essentially from here to here, where I have the calipers, this 3.3 millimeters, this is the acromioclavicular ligament, okay? This nice hyperechoic structure is the roof to the rotator cuff. Now, that's my focus in this view. Underneath here would be your rotator cuff structures in the humerus. Very rarely are you able to get the whole, so out here is the, when I say out here, to the right is the acromion. And so I can't get the whole connection of the ligament with the coracoid in one view. So you have to kind of segment it out. So coracoid, walk it over to the acromion. Okay. Now from this view, this is where you can start looking at, quality. Okay. So as I move him into certain positions, what I'm going to have you do, we can put like a modified Yoakum's, internally rotate, and see that the ligament structure on the top is staying relatively well maintained, okay? It's not bowing, meaning it's keeping its shape, it's staying nice and flat. The humeral head is not migrating superiorly enough to displace it, all right? And we're not seeing any real fraying of that structure, okay? Meaning that this is healthy, all right? You can do maybe a Hawkins-Kennedy in this position, where this is all kind of off the cuff, but I wanted to show you guys this can be done, okay? Hold there for me, hold. Good. And again, no bowing of that structure, okay, as we're coming across body. Now, maybe to the novice side, you're not gonna get a whole lot out of this, but I just wanna point out to you, note how, and relax, note how with those pictures, none of this structure really moved at all, okay? It stayed relatively stable. Those tests and those definitions are loosely based on my anecdotal findings in the clinic. There, to my knowledge, is not a lot of quantified research out there to suggest that this is a standardized test. However, I feel it can be helpful when you're looking at the shoulder, like I said, and putting all these clusters of diagnostic findings together can be helpful in your study.